Hello and welcome to this special edition of COVID coverage. The situation on the COVID front is getting bad to worse. The fresh daily cases now stand at nearly 3 lakh. Nearly 82% of the cases are coming from only 10 states, but the spread of the virus is now spreading. There is a shortage of beds, there is a shortage of medicines, there is a shortage of oxygen. So how is this wave likely to move? How soon will the impact of vaccines kick in? And for everybody who's anxious, worried, tensed about what is the first thing one should do if someone has been detected with COVID, if the basic parameters are falling down, what should be the protocols one should follow? How exactly is the infrastructure now gearing up with this kind of an emergency? So let's discuss all that and much more with the elite panel. It gives me great pleasure to bring on board Dr. Vikram Shah, Chairman and Managing Director with Shalby Limited, Viren Shetty, Executive Director and Group COO of Narayana Health, and then Dr. Sujeet Chatterjee, CEO with HL Hiranandani Hospital. Gentlemen, good afternoon to all three of you, and thank you for joining us. And before I start today's interaction, I just want to take a moment to thank everyone for joining us. Thank you for your time, and I want to sincerely express our gratitude on behalf of 89 Times Network to your staff, to your medical workers who are working round the clock, doing their best for us to fight this crisis. But Dr. Shah, the crisis needs no introduction. The fact that there is shortage of medicine, beds, everybody knows that. What should one do? Everybody is getting emergency calls. Everybody is panicking. When a friend of mine, when a relative of mine is calling up, what should I say and what should be the first port of call?
Well, first of all, let me tell all the people who are listening through your channel that there is no cause of panic as far as routine COVID positive patient is concerned until the oxygen saturation level falls below 92, 93. Because most of the patients do really well until their saturation goes down. So, each and every patient doesn't need to rush to the hospital. They can avail treatment on home care or by their own doctors sitting at home. I would say 90% plus patients can get treatment sitting at home rather than panicking to the hospital. Huge amount of rush can be avoided if patients are not panicking and getting treatment in home care until their saturation really starts falling down.
Mr. Shetty, the rush at the hospital, is it panic, is it fear, or this is the second wave in the sheer numbers which are making it very dangerous? What is the reality? Is it panic or is it dangerous spread of the virus?
It is dangerous spread of virus, definitely, but simultaneously there is a huge amount of panic amongst the people also. So, both the things are together, and hospitals are also getting a lot of patients who are desaturated and requires oxygen and further medical treatment, keeping them in the hospital. So that number is also very high. But if most patients can get treated at home, the unnecessary panic and rush can go down definitely.
Mr. Shetty, let me encourage you with your thoughts. What is your experience at the hospitals which you manage? Are numbers looking high because of fear and panic, or this is a dangerous spread of virus which in a sense is making the numbers look big? Because the spread is so strong, the sheer numbers are so big.
What we've noticed in the early stages of the infection, it is a lot less harmful for patients this time around. We are earlier on, not now obviously, but earlier on we did see a lot fewer patients in the ICU as the disease was spreading, but it is making it up on sheer volume. This is a new strain of virus. It is spreading very rapidly through the country. And of course, our infrastructure has not increased significantly from last year when we already knew that our infrastructure could not handle. And if you're talking about 2x of the official statistics, which would probably be 20 times practically what you are seeing, The infrastructure is simply unable to cope. And so, yes, it does lead to a panic situation and a lot of people coming into the hospital who may be well managed at home, but there are a lot of serious cases. A lot of people deteriorate very rapidly in the hospital, surely because of the volume. Those that can opt for home monitoring are opting for it, as well they should. But the fact is, we're a country of 1 billion people. And so if you have the world's fastest spreading virus coming, it will impact those who have comorbidities, those with diabetes, heart conditions, and cancer problems. And that is what is overwhelming hospital facilities throughout the country and leading to a huge blockage of beds. Meanwhile, we also have to remember that you cannot ignore all the other patients who are coming in for procedures that they have to get done. Every day, people are coming to our emergency room, not just for COVID, but for regular trauma cases. There are people having cardiac arrest. There are people having hip fractures and falling. There are people still having accidents on the road. And hospitals need to take care of them as well. So for us, we cannot draw the distinction between giving priority for a COVID patient who is about to die compared to a patient with a heart attack who's also about to die. They're both extremely important for us. And that's why you have this double whammy of the normal business, which was keeping our hospitals full, combined with the COVID, which is stretching us beyond all capacity.
Mr. Shetty, is it true that there is a shortage of oxygen? Is it true that there is shortage of medicine even in some of the best run private hospitals? I understand that some critical medicines and steroids currently are not there, or we are now reaching dangerous levels of stocks.
We are, but then you also have to understand that this is a very abnormal spike in the usage. If you look at the normal oxygen consumption of every hospital, it operates at a median level, and our storage facilities, our cylinders have planned for that. Now, suddenly, if 30-40% of the hospital is wired up for oxygen, you're going to start running low on supplies, and so you need to get faster refilling. Now, combine that with the fact that every other hospital is also refilling their oxygen cylinders and liquid medical oxygen tankers very quickly. So you find that coming from a place where you have 14, 15 days of buffer to an instance where you have 1 or 2 days of buffer, or in certain hospitals, maybe in Delhi, where it's only about 1 day of buffer. So that keeps us very uncomfortable. We're still able to manage, but it only takes one truck to break down. It only takes one supplier to divert it to another hospital. It only takes one large buyer to say, look, I will corner the market for all the oxygen gets diverted to this state versus another state. These small dislocations become very difficult when you're running on a very thin cushion. And that is the problem. And similarly for remdesivir and other drugs, antiviral drugs, which historically, again, we are the largest producer of drugs in the world, but no drug producer can ever match up to the requirement that will come when all of a sudden 1 billion people decide to buy something. If yesterday they did not want it, and today they want it, and tomorrow they will not want it again, no one is ever going to build enough capacity to meet for that once in a while a spike in demand.
Mr. Chatterjee, how are you managing this entire crisis? What has Hiranandani Hospital done additionally? How do you plan to change things, if at all? And do you have a differentiated strategy in place to surely deal with these numbers?
Yeah, you see, we're a mid-sized hospital, but we are located in Powai, and the Hiranandani community is there. And we have a lot of drainage from the local and the regional areas. So, we've created teams of physicians, as well as people who are super specialists in various other disciplines, for example, cardiologists, neurologists, gastroenterologists. Each and every one of them have been given a zone of responsibility. And, we have gone on the fact that all the super specialists at one time were physicians. So it's a matter of them just brushing up a little bit, and they should be able to treat patients who've got COVID. So therefore, we are constantly rotating teams so that the teams don't get completely exhausted. And also, it's extremely important to triage patients. So the senior most doctors are at the triage, and they triage the patients very, very effectively, because If there is a patient who does not need admission, then in that case, the senior doctor is able to pick that up as well as convince the patient that they don't need admission. They can go in for home quarantine and they can be in regular touch with the consultants. So that's one area which we feel is very, very good and has been extremely rewarding because senior doctors, when patients meet senior doctors, they feel a sense of security. And then after that, if they go to the wards, we've ramped up all the ward beds. Today we are doing almost about 80 patients per floor. So we've devoted 2 floors to for COVID. So we've got 160 patients and 20 beds in the ICU. So we've actually really ensured that the institutional capacity has been increased tremendously to handle this. But happily, all the doctors have plunged into this, crisis, and we are now in a good situation where we have teams of doctors who are servicing each of the floors. And also, there is a team of doctors which is completely rested. So, therefore, when the rotation takes place, they've got the energy to go back and start looking at patients. And we've repeated the same model for the nurses. We've done the same thing for the nurses. And we ensure that there is a huge amount of nutrition provided to all the people who are on the floors. So therefore, there is nutrition, there is a lot of things that go into the nutrition. At the same time, we've also gotten a team of clinical psychologists who are regularly counseling the youngsters. So therefore, the youngsters are also in the critical care units. And the critical care units at this particular point in time is not really a very pretty sight. So therefore, to ensure that the psychological levels of doctors are very well maintained, we have a team of clinical psychologists looking after the youngsters.
Right, fair point. I'm going to throw the next question to Dr. Vikram Shah. And Dr. Shah, it's always tricky to maintain a balance between what the need of the hour is, which is fight COVID crisis, versus maintain responsibility towards shareholders because you are a listed company. How are you managing that? Because the COVID business is something which some would look back and say is not a permanent business, it's a temporary business. If you invest in infrastructure right now, it will cost, but it may not be ROI friendly. How are you maintaining that balance?
Honest with you, we have to rise to occasion and we have to forget about shareholder to start with, because it is very important to take care of our own people for which we have built our hospitals. So it is very, very important that we don't think about other things and help our own people. Second thing is we have already created infrastructure. It is getting in use for people. So we are happy about it that we have created more than 1,800 beds, and today we are our occupancy at 1,400, about 1,400 today. So we are very happy to serve our people, serve our nation, and shareholders will get their dues in a coming time. They are not there for a day or 2 or 15 days. They are there for a long time. That is what I believe.
Mr. Shetty, your hospital chain takes a lot of pride in creating what is called as an asset-light model, which is that you service infrastructure with your expertise and with your knowledge. How are you dealing with this COVID crisis? Are you spending in the infrastructure upfront because that is the need of the hour and ignoring the compulsions of being a listed company?
See, we already have invested in infrastructure. Our ICCUs and our ventilators and everything was ready. So, we have not required to invest much really during this time. We had a capacity of nearly 1,200 beds to start with installed, which we have invested in 300 beds and some ventilators. so as to, fill up our ICCUs as well as our beds. So, we did not require to invest much to increase our capability to 1,500 beds.
Fair point. Okay. Mr. Shetty, how much infrastructure has NH chain of hotels created in last 15 days? How much do you plan to create? And my immediate question is that how will you balance between the shareholder requirement and the need of the hour? Mr. Shetty.
There is no balance. And by the way, a lot of the shareholders themselves will want a hospital bed. So we can't say, no, we're not going to take you because as a shareholder, you are more concerned about the ROI of the bed. And since the COVID reimbursement is not comparable to some other specialty, I cannot take you because of shareholder concern. No, we are people first. And we're doctors, we're hospital. This is what we're built to do. We're built to take care of sick people. When a sick person comes to our front door, our responsibility is to take care of them. Now to the question that you asked earlier, how are we adding infrastructure? We haven't been able to add infrastructure specifically around COVID, precisely because one is it's very unknown to us when these sorts of things happen, but every hospital we're designing in the future. For example, right now, we are conducting two design projects for hospital, one in Mumbai, one in North India. And for them, I made it very clear, the new critical care areas we're designing will have a specific infectious control region. And that is something that all hospital designs going forward will have. You have to assume that things like this COVID pandemic will be with us forever. It may not be so severe, it may come down in severity, but recurrences like this will keep happening. And so all hospital CCUs will have to account for a certain number of patients coming with something highly infectious, and you need to prepare for negative pressure areas and so on to contain that. As for how much we've added specifically, our health city in Bangalore, fortunately, is a very large campus, and we also have the benefit of having a large number of hotels nearby. Similarly, in the Delhi as well, the Delhi government has worked with us to give us access to certain hotels nearby that we can use as COVID care centers. Not just for us, most hospitals have been able to work and partner with smaller nursing homes and other hotels to add more capacity to the patient they're able to manage. But the critical shortage, which is the ICU bed, now that's not something that you can just build overnight. You can't add 100 or 200 ICU beds and assume that everything will be fine. Because ICU is more than just a bed and a ventilator connected to oxygen. To manage a patient means you actually have to manage them with people, with trained intensivists, with trained pulmonologists, with people who are trained in infectious disease and how to manage people who have a multitude of symptoms. Those people don't grow on trees. These are specialists that need years and years of training. And the reason we're struggling so much is not because there's no healthcare infrastructure in the country as you measure by hospitals. There's no healthcare infrastructure in the country as measured by the doctors we produce. Because for decades, the system has systematically produced fewer and fewer super specialists as a proportion of the total number of doctors that are required in the country. And as a result, Indians have to go abroad to train in super specialists. And when they do, very few of them come back. And so these things just can't be erased overnight. I'm hoping that this is the wake-up call that the country and the policymakers need to equalize the undergraduate and postgraduate seats and train a huge number of doctors, not just for our requirements, because emigration is not going to stop when this COVID is over. Because in the Western world, hundreds of doctors are retiring after this. They say, we've had it, that's enough. And where do you think those countries are going to look for when they need to replenish their staff? They're going to look at us. And our doctors are pretty tired as well. They will gladly look at offers that are 10 to 15 times what they're currently making with a much more relaxed pace of life. So unless we rapidly scale up the number of training positions and the number of medical colleges in the country, we will face a massive problem in the next 5-10 years.
Well, that's such a great point, and that's really the long-term perfect solution in terms of how we can really deal with not infrastructure, but again, in terms of providing care, understanding, and service. Mr. Chatterjee, what is your understanding on of the medical situation? There is data available based on first wave. There is data which is there based on second wave. How bad it could get before it gets better?
Well, the epidemiologists who've studied the pattern of the second wave say that the incremental rise is very much more and faster than the first wave. But when the rise plateaus, then the fall is also much faster in the second wave as opposed to the first wave. So therefore, at this particular point in time, I see that the wave is continuing and the peak has not yet been reached. But once the peak is reached, and I reckon that it should be somewhere around the middle of May to third week of May, where we would see a peak plateauing, and then of course I think that there will be a decline, and that decline will be quite rapid. That being said, it doesn't mean that we are done and dusted. Because there will be a lot of comorbidities as well as complications of COVID, which will continue for a while. And so therefore, that's how the entire situation is going to get prolonged for a bit. So therefore, we are here for a long haul, and we must be ready to adapt to the various unfurling situations which are going to be happening as far as the second wave of COVID is concerned.
Dr. Vikram Shah, this question is coming your way, sir. When do you think the vaccine will start kicking in? 12% of India already is vaccinated. The mass vaccination will open from 1st of May. Anybody above 18 is eligible, not entitled, but eligible for a vaccine. When do you think the vaccine will be able to break the chain?
Well, we have to do at least 1 million vaccine, minimum 1 million or 2 per day to achieve something reasonable before the third wave comes.
Okay. Mr. Shetty, if the wave takes its natural course and we are nowhere close to the peak, which is it is 2 weeks, 3 weeks, and the vaccine then kick in, what happens in the interim? I cannot even imagine that right now it's a nightmare, and if this entire spread continues for 3 weeks, then it's not going to get bad to worse, it's going to get horrible to terrible.
What do you want me to say to that? We reap what we sow. This is, it's terrible. We just need to take one day at a time. We cannot let this overwhelm us into a feeling of numbness. The doctors are on the front line doing everything that they can. The vaccine manufacturers have ramped up their capacity. The drug makers have all ramped up their capacity. So have the oxygen people. We do as we always do in India. We just muddle along somehow. Things will work out in the end. And just pray to God that, they see us through this.
I know I've asked you a difficult question, but that's the way everybody is. The whole fear, the whole crisis is so large that everybody in a sense is trying to understand. Mr. Shah, let's talk about the vaccine administration. 1st of May it opens. How easy do you think it will be for us to start the vaccination process? In the first round, there was a little bit of vaccine hesitancy. Now there is a serious case that are vaccines effective? If they are, then why people who've got the first shot, they are also they are contracting a vaccine? Where do you see things moving on the vaccine front? A, in terms of the logistics, B, in terms of this entire fear of vaccine hesitancy and effectiveness?
Well, as far as the vaccine hesitancy is concerned, I think media and government both should take it up and send a message to the people that they need it and they should go for it. And it is everybody's responsibility that we put positive thoughts in people's mind that they need it for the better of themselves, their families, and nation all. As far as first wave and second wave in between vaccination is concerned, each hospital was doing more than 200, 300 vaccines per day. That is not going to be enough because it is 2,000 to 3,000 per day. Government will have to open up schools, clubs, and all those places and take the help of corporate hospitals, government hospitals, and their staff to mass vaccinate at outside the places other than hospitals also.
Dr. Chatterjee, let me get closing comments from you. The vaccination for 18 plus, that window opens from 1st of May. What is your sense on the preparedness? Because clearly, if there is going to be a rush in the first 4 or 5 days, there could be this fear of vaccine shortage. And do you think if people are lining up, that also could end up, becoming more like a super spreader event? How do you see things moving on the vaccine front from 1st of May?
It's anybody's guess, really. I mean, if you're talking in terms of are we prepared, as we speak today, we don't have a vaccine to give people. So therefore, it's anybody's guess how it's going to pan out. But the point that needs to be addressed, and very carefully too, is that it's only 50% of the vaccines are going to be coming into the private domain, and that is what we have to pick up from the manufacturers. So therefore, there's going to be a costing, and there are going to be logistic problems of how we're going to be able to collect the vaccines, or will it be distributed from a central point? Will it be intercity? None of that has been cleared, and neither has the pricing been cleared. But again, if there is, it's not that we don't have the experience of giving vaccination and doing a large number of cases. The throughput in my hospital between 9 a.m. to 6 p.m. Was almost 600 cases. So it is possible to have, a large number of beneficiaries vaccinated. But if there is a huge collection outside the hospital of people who want to get vaccinated, then it becomes a sort of a law and order sort of situation where you really require to control crowds. But I think what we are planning is the appointment system. So therefore, if we get the suitable data on how much we can charge, then in that case, we would start opening the appointments, and we would definitely advertise the fact that people who come in with appointments will be treated first. Now, walk-ins will also be attended, but they will just have to wait their time out. So therefore, we are gearing up in this particular manner is that can you arrange or give appointments, pre-appointed people who can walk in. And even if they're 18 years old or younger or older, we are completely agnostic to that. But the fact of the matter is, it should not lead to a law and order situation where a large number of people come in at one particular time and the hospital is not able to manage. But the vaccine, it is going to depend a lot on the producer, the manufacturer, on how much hits the market. So therefore, even if a large number of people come in and at the back end you are well stocked, then in that case, I don't think there will be a glut in the market.
Well, gentlemen, once again, really appreciate your time, and a sincere gratitude to your staff and to your team for working round the clock to help us win this corona war. Stay safe. Thank you for joining us. And that's it on this special COVID coverage on ET Now.